Welcome everybody, my name's Jim Hunt and I'm a nurse educator here at Insight. I'd like to welcome you to another Insight APSAD webinar. Before I kick off, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting today and pay my respects to elders past, present and future. And I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us out there in webinar land. So welcome and thank you. Today we've got a bit of a target audience specific webinar today. It's on opioid treatment, but I'm pleased to say that it's actually by two colleagues of mine. So we've got Peter Cochrane and Tracey Veitch, who have been employed with Insight for, they'll correct me on this, but around about a year, maybe a little over. And they've been working on the SCOT Project, which is the Shared Care Opioid Treatment Project. So without much further ado, I'm going to hand over to Peter and then Tracey will come on later to do her presentation. So Peter Cochrane, if you'd like to come and present on shared care.
Thanks very much, Jim, and thanks for the opportunity to come and talk about our project. So, as Jim said, this presentation is about the Shared Care for Opioid Treatment, or SCOT Project. The project was made possible by the Nurses and Midwives EB10 Innovation Fund, which was established to fund projects that improve, scale up, enhance, develop or implement models of care that are innovative, flexible, and which address emergent or unmet healthcare needs where nurses and midwives contribute significantly to healthcare outcomes. And to provide some context for opioid treatment, in Queensland, people receive treatment for opioid dependence under the Queensland Opioid Treatment Program, or QOTP, which provides a regulatory framework for the provision of prescriber and dispensary services and treatment admission and discharge requirements. Queensland Health's Monitored Medicines Unit maintain administrative oversight of the QOTP, while treatment is administered by the public hospital and health services and private prescribers. And medications typically are administered and dispensed through community pharmacies. So today, I'm going to provide an overview of the drivers for this project and how we went about developing the shared care model for Metro North Mental Health Alcohol and Drug Service. And Tracey will then outline the procedure and health professional roles in this shared care model and introduce a suite of documents and resources developed to support the model. So I'd like to start by providing a few definitions just for clarification. First of all, what is shared care? Well, traditionally, medical and nurse practitioners would undergo training and obtain approval from the Chief Health Officer or their delegate before they're able to independently prescribe QOTP medications. So in our Queensland medication assisted treatment guidelines for opioid dependence, they outline a shared care definition where the patient treatment will remain registered with the Alcohol and Drug Service and the patient maintains access to their case manager. The approved prescriber will monitor the patient and provide ongoing written instructions or scripts. However, the approved prescriber is not expected to undergo any training to become an approved QOTP treatment provider. So in a typical patient journey, the patient would attend the Alcohol and Drug Service for assessment, planning and goal setting, treatment commencement and stabilisation. They would then transfer to their approved prescriber once they're clinically assessed as stable against predefined criteria. Second, while we recognise that a GP is the most likely health professional to be the patient's shared care provider, it is acknowledged that other medical specialists or nurse practitioners may fulfil the role in the community. Collectively, we recognise all of the health professionals that take a role of shared care provider as approved prescribers. And finally, while Alcohol and Drug Service staff often call or refer to the people that they treat as clients, health practitioners in primary health care, and in particular GPs, refer to the people they treat as patients. And it's our experience that speaking in a language familiar to GPs assists in discussing the shared care treatment with them. So in this presentation, we'll refer to those people as patients. So this project was driven in recognition that the government commitment to implementing opioid treatment programs within all Queensland prisons would increase or result in a significant increase in demand for treatment services from people attempting to manage their substance use prior to entering prison and on return to the community. At the time, our alcohol and drug service were operating at capacity with over 1,100 patients, and it was estimated that the introduction of treatment in prisons could result in several hundred more cases, several hundred more patients in our hospital and health service catchment area. So our aim was to establish a sustainable model of shared care for opioid treatment patients, moving stable patients into a more appropriate setting and increasing the capacity of the alcohol and drug service to provide timely access for those requiring tertiary care. So that is the new assessments and the more complex and high-risk cases. Now, due to a delay in further implementation of treatment in prisons, our focus really turned to the management of stable patients to increase service capacity in anticipation of the prison services. So we began by researching shared care models and talking to people involved in the implementation or attempted implementation of shared care models. And we'd like to thank all of our colleagues from Sunshine Coast, Central Queensland and Metro South Hospital and Health Services who provided some great information regarding their own experience in implementing shared care models. So we sought to determine the benefits and therefore the value of shared care and identify the barriers and enablers of implementation. We found that there are several benefits that could be expected from a shared care model. Generally, patients appreciate the normalised approach to care and the ability to address all of their health needs in one place. It provides a holistic health approach, which can improve general health monitoring and preventative health checks. And it supports a recovery approach that promotes patient responsibility for their own health. Other research has shown that there is no significant difference in rates of retention between patients in shared care and those under specialised alcohol and drug service case management. Across the system, there are better quality relationships between alcohol and drug services and primary healthcare services, so that allows for improved referrals and increased cooperation. For approved prescribers, the supportive shared care arrangement may encourage them to take on further patients, and the experience of managing care for stable patients can improve their confidence in treating and their perceptions of people experiencing drug dependence. GPs generally report having a better understanding of alcohol and drug issues and describe the experience as largely rewarding. And this may also lead to approved prescribers becoming authorised QATP prescribers in the future. And for the alcohol and drug service, it can improve access due to a reduced demand on medical officer, nurse practitioner and case manager time for routine appointments and scripting. And in addition to all of this, the shared care model actually aligns with several Queensland Health, Metro North Hospital and Health Service and Queensland Mental Health Commission strategic plans and clinical guidelines, as well as the National Safety and Quality Health Service standards. So our research found that there are several reasons why shared care or moving patients to a primary care setting has failed to be implemented or maintained. GPs have historically been reluctant to take on treatment of opioid dependence. They report being concerned about the type of patient that participation with an opioid treatment program will bring to the clinic, and being inundated with people requesting treatment for drugs or requesting treatment or drugs when they are known as a prescriber. Patients are often also referred on or refuse treatment because the GP might lack specialised alcohol and other drug knowledge or experience. And becoming a prescriber is seen as time-consuming and a role that is unsupported by specialist services. And finally, GPs were concerned with the amount of time they believe patients would take up and the lack of meaningful payment for that time. And while we acknowledge that some patient presentations are very challenging, overall there's little evidence to support that these concerns are for a shared care provider, as they are more to do with tertiary care services or being a registered QATP treatment provider. When we explored unsuccessful attempts to move patients to a GP, a common issue was that the GP was required to become a registered prescriber, rather than a treatment provider in conjunction with an alcohol and drug service. But there are also successful shared care models nationally and overseas. So we look to these to find the common factors that help make shared care work. Most common enabling features are identification of stable patients, establishing a role, a support person for the approved prescriber. And this could be a designated clinical coordinator or a portfolio held by a clinician in the service. Case managers maintaining or retaining the responsibility for their patient's care. The approved prescriber having access to specialist medical officers and information when required. And some flexibility that allows the approved prescribers and clinics to find the best fit. While GPs were not interested in becoming registered prescribers of treatment for opioid dependence, the supported shared care arrangement, where the GP is not known as a prescriber, has proven to have much better acceptance. So it became apparent that any implemented model would need ongoing alcohol and drug service support with ease of access to specialist knowledge when required. So Tracey and I started thinking about this and how we would approach it. Just have a representation here. That's our mind's thinking. Some scans that were done at the time. And if you can see the error codes come up, that was my brain. So we thought addressing the barriers was a good start. Knowing we have access to some great Queensland resources such as ADCAS, which can provide specialist clinical advice, Insight, which has contemporary and engaging education and training resources, and ADIS, who are able to connect clinicians to support services, we realised that the structures to provide specialist advice, education and information already existed. We just needed to make this known to the primary healthcare professionals who we wanted to engage in shared care. And in fact, several barriers could be addressed with good information. We also needed to inform and educate potential prescribers on what a stable patient looked like, how we would collaborate with them, that the patient management could actually be handed back to the alcohol and drug service if required, what they were actually expected to do as a shared care collaborator, and identifying other support networks that existed. And finally, we knew that we had to put this information and support structure together in a package, along with a model of shared care, to reduce the demands on the approved prescribers and the alcohol and drug service. So shared care is founded in collaborative practice. So during the initial planning, we were identifying our stakeholders, who they were, and engaged with them. Initially, we went old school with a lot of face-to-face meetings. And then, like everyone else, we had to adjust the way we met. Our stakeholders included the leaders and staff of our services, the primary health network for our region, and the Institute for Urban Indigenous Health. We started to visit individual general practices and pharmacies and NGOs. We began introducing documents that we were putting together to assist in the implementation of shared care, and we were getting feedback and making sure that those documents that we were developing were actually meeting the needs of our shared care collaborators. As they were being fine-tuned, we were provided with an opportunity to present the concept of QOTP shared care and our documents to the PHN Clinical Advisory Group, who supported our approach and believed that the model aligned with their own strategic direction and values. In developing information for our patients, the Alcohol and Drug Service Client Advisory Committee provided support and encouragement for the model and valuable input into the information brochure. Pharmaceutical reps working in the sector provided connections to medical practitioners and pharmacists interested in working with this patient group, and opportunities for us to promote our project. And our colleagues working at Insight provided great support in helping us to develop our resources and assisted in our methodology for developing the model. As mentioned earlier, in addition to having a framework to our model, we needed to define what a stable patient would look like for our service, as this would form a significant part of the model. Our colleagues suggested using a modified Delphi method to do this, which I then needed to find out what it was. So Delphi method is a structured communication that relies upon experts to make decisions. So they answer questionnaires in more than 2 or more rounds. And after each round, they're provided with an anonymized summary of the previous decisions. and any reasons provided for the decisions in the previous round. In subsequent questionnaires, the experts may revise the earlier answers in light of the previous questionnaire results. So it's expected that the range of answers will decrease during this process and the group will converge towards the correct decision. And finally, that process is completed once a predefined criterion is reached. So essentially a consensus, and we could define what a consensus was for a decision. So to develop a model of shared care appropriate for our service, we used a modified Delphi method, where we acknowledged that the components or elements of treatment for opioid dependence were largely regulated or well established. We use this method to explore general elements of shared care, patient stability, required assessments, approved prescriber responsibilities, and psychosocial support. Our first questionnaire then, rather than asking open questions, was created incorporating components of shared care models used within Queensland, New South Wales, and internationally. Clinicians were presented with 41 clinical guideline statements and asked to provide yes/no answers in response to the statements and provide further commentary if they chose. The responses were then used to refine the model and generate other elements for consideration. Consensus was achieved on 24 of these elements, 3 of which were determined to be irrelevant to shared care. Our second questionnaire asked the clinicians to reconsider 2 of the elements presented earlier, refine 15 other elements, and consider 4 new ones. And finally, a third questionnaire was conducted as a face-to-face discussion with medical and nurse practitioners and nursing team leaders. It was conducted this way as there were only 6 elements needed for clarification, and these mostly related to prescribing and service structure issues. So as an example of how this actually worked, the first questionnaire asked if patients treated with methadone should be considered for shared care. There was a consensus that they should, but several of the comments indicated there might need to be limits, dose limits placed on this. So in the second questionnaire, clinicians were provided this feedback and information from clinical guidelines and were asked which of 3 doses should be considered as an upper level or a maximum dose for shared care. Again, a clear consensus was not found. In the final discussion, clinicians were informed of the previous results and then reminded that patients would be assessed as psychologically and medically stable after being reviewed by the multidisciplinary team. And the dose could not be independently altered by the approved prescriber. So these were elements that had been of the model that had previously been determined. The result was that there was no upper limit. However, for anyone on a dose greater than 120 milligrams, the approved prescriber had to engage in regular monitoring, including the performance of ECGs. So for this procedure then to be developed, we used the collective expert opinion of our service and developed the model of care procedure. While this procedure still required final consultation and endorsement, the process was made quicker because the decisions had already been made. I'm now going to hand over to Tracey, who's going to take us through the different roles and the packages that we have developed. Thank you.
The introduction of any new process into a busy ADS is generally met with some angst and clinician stress, as workload concerns are quite naturally foremost in the mind of all. However, this process has been designed to support the clinician with no real-time constraints and the support of case manager, approved prescriber, and pharmacist packs. It can easily be incorporated into the business as usual, clinic's business as usual. The following slides will take you through the roles of each of the shared care participants and the supports that have been put in place to ensure the process is as easy as possible. So the case manager's role. The case manager plays a pivotal role in the assessment, transfer, and maintenance of shared care. They will assess their patient's suitability for shared care at each scheduled review and coordinate the movement of the patient to an approved prescriber when appropriate. They will also provide support and guidance to the approved prescriber when they are required once approved. Shared care is now the expected model of service for Metro North Drug and Alcohol Service. However, it is acknowledged that patients require treatment plans matched to their individual needs, and therefore timelines for transfer to shared care can differ significantly. What this actually means is that some patients may need very little case management and will transfer to shared care quite quickly. But those with more complex need may require more time in case management with the service before they could be considered for this model. And then there are those who present with chaotic drug use behaviour and significant complexities that may never quite meet the suitability criteria. We have developed suites of documents for all those involved in the shared care process for our patients. And these have been designed to be quick and easy to use, ensuring consistent delivery of information and role requirements. The documents in the Case Manager pack are numbered in order of use and consist of guides, prompts and required documents to assist in the assessment and transfer of patients to shared care. The first document there is a guide for determining stability and multidisciplinary team discussion. Secondly, there is another guide, and this is to help with discussions with patients and GPs or other potential prescribers. It has the answers to many of the frequently asked questions, and this is for clinician guidance only and not to be distributed between prescribers or patients. The third one there is a prompt to ensure there is a current signed patient consent form to allow discussions with their potential prescriber. There's a template for a follow-up letter that should be sent to the potential prescriber after a discussion requesting participation in shared care. This can be personalised by the case manager if they wish, or add in extra information that they feel necessary, but it can just be used as is also. As is with all correspondence, if emailing this where you've got the patient's name, you would actually put your patient. If faxing, you can put the patient's details in there. That fifth document there is the application to the MMU for approval of shared care between a specific prescriber and patient. It must be completed once a potential prescriber has agreed to participate in shared care and should be faxed or attached to an email to the QOTP. Document 6 is another prompt, this time to complete a transfer document, a Queensland Health QOTP form, the latest treatment plan, or even a handover letter may be used. This is to ensure that the prescriber is given an appropriate handover of the patient's treatment history. Document 7 should be completed and provided to the pharmacist once approval for shared care has been provided and the approved prescriber has been set up for the transfer of patient care. The pack also has a response letter that can be used in the event of a patient being referred to the service for review and possible treatment for opioid dependence. If the patient is deemed suitable for QOTP, you can send this letter back to the referrer to inform them of the shared care model and initiate their involvement once the patient's treatment is stable. There is a flow chart that can be printed and pinned up in the case manager area or workstation. A checklist that can be attached to the front of the patient's chart once the shared care process has commenced to keep everybody on track. And a brochure that you can provide to the patient when talking about shared care. Along with the documents, the clinics have also had access to a short video our team developed to answer common approved prescriber questions. This can be sent to potential approved prescribers or used for educational and promotional purposes and will soon be accessible through the Insight website for those outside Metro North area who are interested in establishing a shared care model.
The Shared Care for Opioid Treatment, or SCOT Project, aims to develop a sustainable model of care for people experiencing opioid dependence by partnering GPs, specialist alcohol and drug services, and other local healthcare providers. This brief video aims to address some of the common questions and concerns voiced by GPs and practice staff. It is hoped that the information will help to clarify some of the questions you might have when considering working with the Alcohol and Drug Service to provide shared care for opioid treatment.
What support will I have as a shared care provider?
The shared care model of treatment has been designed to be a fully supported program for you. So we at the Alcohol and Drug Service understand that traditionally this has been a complex area that not everybody feels very comfortable with. So therefore we've put in place a whole range of supports for you. You will have access to a case manager for your patient to be able to talk to or to answer any questions you might have. We also have specialist addiction medical officers to talk to. There's also phone lines, so there is a clinical advisory line and a patient support line that is available to you. We can come in and help your practice staff get ready and get comfortable with assessments. We can help you set up the documentation and administration. You also have the right of referral back to the service. So for any reason you're unable to cope with the shared care program or you're unable to continue prescribing, you can refer back to the service and we will take them back.
I'm concerned there may be pressure to take on high numbers of QOTP patients.
So the aim of the shared care model of service is to provide a holistic care of our patients in a relevant setting. And this will allow the drug and alcohol service to take on those more complex patients that require a high level of case management. So we're just asking you to work with us to monitor the general health of our patients and to ensure their stability continues. We will always contact our patient's GP first. However, there may be times where we have a patient that doesn't have a GP and we might give you a call and just see if you're willing to take them on as well. You will never be expected to do so. You will not be known as a QOT prescriber and no individual will be able to approach you on their own. Our aim is for shared care to become a more normalised model of service, so people will be seen by their primary health care providers in the community. You will never be asked to take on any particular number of clients. You will always be in control of how many that you see, and that number will be respected by our service.
Will patients receive support other than from the Opioid Treatment Program doctor?
While the alcohol and drug service is only going to transfer patients who are stable in their treatment, sometimes they need a little extra support. Even though you're now managing your patient's opioid treatment, you can still refer them to the case manager at the clinic for some additional support or if they need some psychosocial counselling. In addition, your patient can always contact ADIS, the 24/7 alcohol and drug support telephone line.
I have concerns for the safety of myself, my staff, or other patients by taking on patients on QOTP.
While there are no evidence suggesting that opiate-stable patients are far riskier than others, we value your concern. We only aim to transfer patients who are stable in their opiate dose, patients who does not need intensive care support from our specialist clinics, and these are the patients who have had, better health outcomes in our clinics. As a doctor, it is rewarding to see that our patients benefit from our care. Let us now take this opportunity to bring all aspects of our patients' care under one roof.
I'm concerned I will be targeted by regulators for my opioid prescribing if I take on a shared care patient.
Some doctors are concerned if they become a shared care provider for a patient on an opioid treatment program, that their ability to prescribe opioids for their other patients will be restricted, or they'll be identified as a high-level opioid prescriber by regulators. This is not the case. The Queensland Health Monitored Medicines Unit will approve you as a shared care provider to treat a specific patient with a specified opioid treatment medication. As long as these conditions are maintained, being a shared care provider will not affect your usual prescribing practices.
So once an approved prescriber has agreed to participate in shared care and manage the patient's treatment, the case manager would apply to the MMU or the Monitored Medicines Unit for approval to enter into a shared care arrangement for that patient only. This approval, once granted, is not transferable to another doctor, so they can't ask a colleague in their practice to provide scripts while they're on leave, for example. And the approval does not allow the approved prescriber to treat any other QOTP patients. As previously mentioned, the approved prescriber would not become a QOT prescriber, excuse me, and their role would be to monitor and maintain treatment and provide quarterly reports to the case manager to ensure case review requirements are met. It is expected that the AP or the approved prescriber would incorporate the QOTP review with other health or script review appointments where possible, and this would not necessarily need to be a separate appointment. The approved prescriber cannot change the medication dose independently, but should contact the case manager for guidance if the patient requests. A dose change could be initiated by verbal order with written confirmation sent by the case manager or medical officer, or they may be instructed to refer the patient back to the service for a review. They must also contact the Alcohol and Drug Service for advice if any concerns around the patient's stability arise, and before prescribing any new benzodiazepines, gabapentinoids, antipsychotics, antidepressants, or any other opioid medications or reportable drugs of dependence. They can, however, change TADs in line with the MATOD guidelines, change pharmacies at the patient's request, or authorise double or triple dosing for those on Suboxone or Subutex in line with the MATOD guidelines. So once the prescriber has been approved by the Monitored Medicines Unit for shared care participation, the case manager will contact the approved prescriber within 7 days to ensure that they are not left wondering what to do with the approval and provided documents. At this time, an appointment will be made for the case manager to visit and provide the following documents and ensure the role responsibilities are clear. Whilst these documents have been developed for the approved prescriber, the case manager will need to also be familiar with them. The case manager will pre-fill patient, approved prescriber, and pharmacy details on all applicable forms and supply digital copies to the approved prescriber at the scheduled appointment. You'll find these packs are set up like the case manager's folder, numbered in order of use. So in the document folder, we have a suggested patient review. This is another that's just a guide only. It's not required to be used. It's more likely that stable patients that are being transferred will just require a check-in to ensure they have no issues have arisen. But this can be a good guide for people that maybe are not feeling so confident in doing a opioid review. There is no document labelled number 2, and this is intentional, as the case manager will save the QOTP written instruction template supplied by the Monitored Medicines Unit on approval in this spot. Document 3 is a reporting template the approved prescriber is required to complete and fax to the case manager at least every 3 months to meet case review requirements. Document 4 is a referral template if required. The approved prescriber should always be encouraged to talk to the case manager if there's any concerns, but if they need to return them back to the Drug and Alcohol Service for review or for continued treatment, then they should complete this referral and send it back. There's a pharmacy introduction letter, and the case manager will need to insert the patient's photo into this document and complete the patient and approved prescriber details. It's to be used if the patient wishes to change pharmacies. As this is not expected to be a common request, the case manager can advise the approved prescriber to call for guidance if this is necessary. The 6th one there is a document guide, and this has instructions for the approved prescriber on when to use each of the documents and how to complete them, including the written instructions. This is also useful for the case manager, as it will help to set up the approved prescriber for patient transfer. There's a resource folder as well, and this one will include the approved prescriber responsibilities, and a printed copy should also be provided to the approved prescriber at the setup appointment. There's a drug interaction sheet that has been taken from the MATOD guidelines and is just a quick reference tool. The complete guidelines are also provided, and some Medicare rebates suggestions. However, these should be a guide only and do not replace the approved prescriber responsibility to use appropriate codes. And then there is a SCOT flyer, and this provides the clinic, case manager and support contact information. It's also suggested this one be printed and provided to the approved prescriber. The pharmacist's role has not really changed, and there's only one document the pharmacist is required to complete. This should also be pre-filled with patient, approved prescriber and case manager details. The pharmacist is asked to complete this every 3 months and return via fax to the approved prescriber and to the case manager to assist in early identification of any issues. So once the transfer process is complete, the case manager should provide the patient an appointment for review in 6 months with the clinic medical officer or nurse practitioner, just to check in and make sure all is going well. Clinic reviews will then occur annually. When commencing shared care, it's a good idea for the case managers to place a task in their diary to request reports from the approved prescriber and pharmacist if they are not received. Any issues that have been identified can be discussed at a multidisciplinary team review and addressed as necessary. If there are any changes to the case manager, the alternate contact person, or clinic information, the approved prescriber and pharmacist will need to be advised. The SCOT flyer in the approved prescriber resource pack can be used to provide this information. So during this project, we have worked with our clinicians to ensure the resulting procedure, document packs and supports are relevant and manageable. We now have 18 patients in shared care, with clinics now starting to work the process independently. A point to note here is that that's 18 patients with 18 separate doctors across Metro North. And at this point, we have not had any doctors refuse shared care. In fact, the response has been incredibly positive from doctors, pharmacists, and the local PHN. We have also presented in GP and pharmacist professional development webinars, promoted shared care in an article published in the PHN newsletter, and packaged material for the development of shared care that will be presented as a toolkit by Insight, including instructional videos for the case manager and the approved prescriber. This will assist other hospital and health services to introduce shared care if they are wanting to. Unfortunately, although this project was slated to run for 12 months from last September, staff unavailability meant we had a delayed start time and reduced project period. COVID reduced access to patients and medical centres, and clinician workloads increased as a result, also impacting our additional desire for our outcome for a longer implementation period, which would have ensured all clinics were comfortable and able to sustain the model of care. We would have liked to assist clinics to develop a portfolio position that ideally could have been general contact point for shared care, providing approved prescribers and their staff with education and regular updates on alcohol and other drugs, CPD opportunities, prescriber opportunities, and clinic changes. We've also would have liked to have completed further research into the ongoing implementation and acceptability of the model by clinicians and patients. The discussions we have had, although have really backed up our initial research and show that patients are happy to be able to manage all their health needs in one place, especially those that have previously been required to travel some distance for appointments or have full-time work or family obligations. Approved prescribers have stated they are surprised at how easy everything is and are appreciative of the level of support that has been built into the model. Staff have indicated that they are happy with the suite of documents and that they find the process is logical and easy to follow. While share care is still very new to Metro North, the outlook is very positive and will free up medical officer, nurse practitioner and case manager appointments, allowing those that really need our intensive help to access it in a timely manner. Thank you.
Thank you very much, Tracey. Excellent, and for me, an exciting project over the last year to see that develop. The reason that I say that is it was one of the last jobs I did about 10, 12 years ago before I came to Australia, was shared care was coming out in the UK, and I saw the benefits there, so it's exciting to see it happen here. I should point out to the people that have written in questions, so thank you for that. Due to COVID, we've now had to put Pete, who did the initial part of this presentation, on a laptop in another room just so that we can talk without having to have masks on. So please bear with us if there's a delay or a lag with sound. Hopefully, Pete, you can hear me okay. I've got some questions that I'm going to run through. Firstly, you mentioned that a GP's lack of knowledge may have a bearing on potential outcomes for patients, around GPs, obviously general practitioners, not specialists in AOD. Is there specific training that GPs can do so that they're better able to support clients around that?
Sure. So we actually refer them to Insight generally, to the Insight page, but the GP support services also have their ACRAM training and things like that. So there's lots of actual training out there, and we do guide them to that if they're interested. But as far as the shared care model goes, we really give targeted education into what their particular patient needs and what they are required to do for their patient, because they don't have to change the dose, they don't have to and they sort of get guidance from the clinic with any sort of extra drug prescribing, they've got a lot of support and they're not really needing to get that intensive education.
Yeah, thank you. Feel free to chip in, Pete. I can't actually see you, so just shout if you do want to respond. This one actually may be one for you, Pete. You mentioned about this was brought about because of the possible influx of people around, being released from prison facilities. And somebody's actually written in and said, are any male prisoners able to receive opioid treatment currently in Queensland in prisons?
Yeah, good question. So the treatment services across prisons, just as a complete update, not just about the men, but so all female prisons across Queensland provide opioid treatment services, and that includes the private facility at Southern Queensland Correctional Centre. And for the men's, it currently is operated out of Lotus Glen at Mareeba and also Townsville Men's Correctional Centre. So when it was being implemented, it provided the ability to move prisoners between those two northern prisons and maintain, allow some correctional management to occur while keeping the opioid treatment close by, like rather than have it spread out over the state. All of the rest of the male prisons from central Queensland down into southeast Queensland would be in that next phase of implementation. So not available yet, but will be coming.
It is coming. Fabulous. Thanks for that, Pete. I guess another question is, excuse me, is shared care operational anywhere else in Australia? Were you able to kind of talk to other services that are already doing it to kind of model on? If somebody wants to respond.
So other states do have versions of it going, and it depends because like example in Victoria, their QOTP is all done in private practice. They don't have the clinics. So it just depends on how the different states are actually running their program as to how shared care is going. New South Wales do a lot of shared stuff, but they also had a lot of involvement of getting the GPs as QOTP prescribers. So there was some difficulties there. In Queensland, Sunshine Coast have got a model going, and they've got approximately 10% of their clients out in shared care. And we did talk to them, so they were very helpful. And Central Queensland have developed a policy, but they said they basically haven't had a chance to put it into motion, so they haven't got anybody in shared care.
Hopefully in the future.
Hopefully in the future, and some of this might help them as well.
Sure.
And certainly Metro South have also had some work done in this area. And so we talked to them as well, but their numbers aren't large either. I don't know if anyone from Metro South's out there that, Mandy, if you're around and you could confirm that, but they've certainly done some work in this field as well.
But hopefully it's going to be an area that's going to grow, I think.
Yeah.
How do you see the bringing in the last 12 months or so of the long-acting injectables? How do you see that impacting shared care? Is it likely to change the face of it at all, do you think?
I think it'll be excellent. Be excellent because, and it's still something that is going to be coming in the future. But you can see that GPs have a practice nurse, so they can do the scripting, they can do the injecting. A lot of them have chemists attached to or across the road or just nearby that they can get their injectable from. The pharmacies don't actually have to be registered QOTP prescribers, so it's a lot easier for them to get hold of. So it's really an exciting way to see that go.
It should be a good addition to the toolkit.
Yeah.
Lovely. Currently, with the model that's in place, so say you've got a client that's gone out to shared care, so they're still essentially managed kind of by the AOD service, but being seen and supported by their GP. When it comes to actually doing the clinical review side of it, does that happen in the AOD service? Does it happen in GP land? How does that kind of work?
So the GPs will do the general 3-monthly reviews. And they're given some education as to what sort of stuff that they need to be looking at and the sorts of questions they need to be talking to their patients about. With our 18 patients that have been out there, as we said, they've all had their own GPs. So their GPs are actually quite familiar with them. I think all but 2 actually knew that they were on the program. The 2 that didn't know on the program didn't know that they were on the program were quite surprised and didn't realise they were that sort of patient.
The usual stigma association.
But were very quick to get on board and very happy to be involved. So so they're sort of they're educated in how to do those general reviews, and then, as we said, we bring them back in 6 months just to check everything's going okay, and then after that annually.
Cool. Just a couple of people wrote in about acronyms. We kind of answered that, but MMU, the Monitored Medications Unit, is so for those that aren't familiar, that's the service that kind of oversees all of S8 prescribing. Now, obviously, we're talking about moving stable people out to shared care, but life has a habit of throwing us curveballs every now and then, so stability isn't a guaranteed thing. When I was working in QOTP in Queensland, if one of my clients went and accessed another prescription from somewhere else, I would be contacted by what is now MMU to be advised of that, and maybe bring the client in to have a chat with them and see what was going on. With the system in shared care, who finds out if this stuff happens? Does that make sense?
Yes. So the approved prescriber will be informed, but the case manager, the MMU have said that they're the case manager, or the clinic would also be, because they actually on the approval and on the actual prescription, it's all listed as shared care. So it goes to both people.
Perfect. Highly important question from me, so thank you whoever wrote this in. What do you see as the benefits of shared care for the clients in real world time, real world conditions?
So for the clients, it's a bit more flexibility in getting to their review sessions, so they can go in on weekends, they can go in after work or after school hours or whatever. They're getting and Pete did sort of run through in that benefit slide, but they can get all of their health needs met at once. They don't have to, if they're on medications for maybe their diabetes or heart problems or whatever,
it can all be talked about.
Everything's all sort of talked about together, and it's just another script review. So they're getting their scripts for their other medications. They address their QOTP as well.
For me, I like the fact that the clients no longer have to go to an alcohol and drug service, which obviously carries with it its own stigma associated with it. And, as it should be, you should be able to go to your primary care provider to get your primary care needs met.
Absolutely. There's a lovely quote in the bottom of that benefit slide, and I can probably
go back to it.
Go back to it. But it actually says that it's taking away from that social sort of support and bringing it back to giving them more autonomy and control around their own healthcare. Sorry, I'm just...
That's all right.
And the patients really appreciate that, especially when they've got to that, they've done their work, they've done the hard stuff, they've done all that sort of psychosocial stuff. That bottom quote there, I think that's a lovely one, rather than in the role of a recipient of a social service. So it's bringing that autonomy and normalisation to the patient.
Somebody's asked, is there any connection out with the GPs out at Woodford or Kilcoy? Have you got anyone out there?
We've got one at Woodford and one at Kilcoy, both involved in shared care.
And again, a highly valuable question, so thank you whoever wrote this. Has the model been adopted or adapted for Indigenous consumers, and is it in any of those clinics that are focused specifically for Indigenous consumers?
So we have, in the actual model, there's no specific forms or guidance for an Indigenous consumer, because that would be or client, because we hope that would come into the clinician's practice, that cultural awareness. We do have the Moreton Indigenous Health Service at Margate and at Strathpine, have both got clinician doctors there that are involved in shared care, and are very excited to be able to support their clients in a very culturally appropriate way.
Perfect.
And they've actually been very proactive in this as well. Once we've visited with them, they recognise and they know some of their other patients within treatment services, and are really keen to support them and get more involved where they can.
Yep.
Perfect. A question here, have you had any issues with GPs not wanting to take on the alcohol and drug service new clients? I know when I did this in the UK, well, it might not have been a specific GP, but sometimes the practice. So one GP might have wanted to do it, but other people in the service were perhaps more nervous. So it perhaps needed some education for all of the practice managers. What was your experience with that?
So at the beginning of the project, we went out to quite a lot of practices just to sort of talk about shared care, how it would work, and any concerns that doctors sort of thought that were coming to mind. And at first, the immediate thing was, we have to be a prescriber, we have to be a prescriber. And that took a little bit to overcome, just say, no, you don't actually have to be a prescriber. And once that came in, they were like, oh, all right, yeah, that's really good. And then when we went more into and spoke to the PHN, they were just like, this is brilliant. These are our patients, so we can treat them like we treat everything else. This is just great. And so we've had actually no GPs refuse. We had one ask to sort of put off the start time because they were doing a bit of transition work in their clinics, which was fine, but then they were happy to take them on. There's really been no pushback at all.
Cool. Thank you. Now, the question does actually say, and if I'm going to read it accurately, it does actually say new clients. Now, my understanding is that new clients wouldn't be started in the shared care model. They'd probably be started with the alcohol and drug and then moved into shared care. Is my understanding correct?
Yeah. So I guess whether they mean,
I don't know if they mean brand new or new to shared care.
So somebody that would be starting on the program, we would try and get them to identify a GP when they actually start with the program. And we would contact them so that they are aware with the patient's permission, and hopefully get them involved in shared care later on. If it's a GP's own new client, they can come to us, still be assessed, stabilised, commenced and stabilised, make sure that all their psychosocial stuff is addressed, and then they can go back to the GP. Perfect. I hope that sort of answers the question.
I think hopefully we've covered that.
Yeah.
Another question, which I think is a good one. If other services wanted to incorporate or bring shared care into their service, what advice would you give them after having done this for the previous year?
Do it. Do it. The patients love it. The doctors love it. Some of the clinics that sort of might find it a little bit overwhelming at first. It's just that new thing again, and something to, I suppose, and there's a lot going on at the moment. So we did find some of the clinics found it a little bit overwhelming at first. But just read it, sort of read what we've done. As we said, we're going to put it up as a toolkit on Insight, and that's just our journey, and people are free to sort of change that and make it their own. It's just so people have got a bit of an idea about where to start, but talk to your clinicians, see what they think is necessary, talk to your patients. Definitely. And talk to your local GPs.
And definitely have support from your service directors, and because it needs to be something that's not really ad hoc, that one clinician's doing and another's not. This needs to be something, I think, that a service agrees that they want to incorporate it as part of business as usual. Not saying that they have to have huge numbers, but that it is one option that they have in their treatment models. And as Tracey, I think, just said as well, really engage as much, because every area is different, I guess, but engage with your PHN early, just to make sure it wasn't too hard for us when they looked at the things that we were providing to help support the model. You know, they themselves were very supportive of it and thought that it would work well. Whereas, you know, you kind of always think that there's going to be a lot of rejection for it. So I think talking to those people and making sure that you're meeting the needs of the people you want to do shared care with.
Yeah. Definitely. And I think having that real structure to it too, so that any clinician can come in and pick it up, rather than a little bit, as Pete said, a little bit of an ad hoc, that so one person starts off doing it this way, another person have that sort of worked out, talk to everybody and get that worked out, how you're going to do it.
And I think that structure also helps support the doctors that are going to be doing it, and allows them to feel more safe and able to, you know, as you said, if there's issues, they have somewhere they can go.
Yeah.
Perfect. I think
that's critical, Jim. Yeah.
Sorry, Pete, go on.
Yeah, your point that you just made is critical. And it's not, I don't think we have had a demand from any of those doctors. They just need to know that you're there to help them. So once you set them up, they're ready to run. And it's not like we've been inundated with them getting in touch with us all the time. There's a few little things that have needed to be sorted out, but it's more about knowing that you've got their back if they should need you.
Yeah, I think when I did it in the UK, one of the hardest things I found was just teaching them how to write a prescription for the medication.
Yeah.
That was about as tough as it got generally. Everything else seems plain sailing.
Yeah.
I think I've just got one closing question, which hopefully you can both give a bit of a response to, which is, now that you've established this, what's your hope for shared care in Queensland?
I'd love to see it sort of picked up and really followed through with, because I think it's just a great thing for the patient that it goes along that recovery journey. It gives them some of their autonomy back, their life. It's taking away that sort of paternalistic clinic case management to somebody that has done their hard work, and that it's putting them back in charge of their lives and giving them back some normality and self-respect. Well, not
I think as I say, it's all about that stigma and everything else. When things are normalised, the stigma decreases and it becomes more acceptable. Pete, do you want to add anything to that?
Yeah, I think that's the main thing actually, is really recognising that there needs to be, not all of our patients are the same. So while some of them do actually like being treated and working with the alcohol and drug service, there are a cohort of our patients that really do want to move on, as you say, Jim, and not turn up to an alcohol and drug service. And it's being able to provide everything that we can. So we are specialist tertiary services in Queensland. We've kind of done everything because that's the way it's been. But if we can just build this and gradually develop it and get that stigma reduced, and see this as just part of another health condition where people can have their treatment out in, in primary healthcare services, and we can provide that tertiary care service and support to primary healthcare services, I think that would be a fantastic outcome for Queensland.
I agree. And I think as a clinician that's worked both in OTP in the UK and in shared care in the UK, one of the things that I used to be a bit anxious about when shared care came out and I was asked to roll this out was, as a clinician, we have clients that we enjoy seeing, and we have clients that are perhaps more challenging to see. And it was there was some reluctance to give up the ones that you perhaps enjoyed seeing because they were stable, and so you knew you weren't going to get nightmares out of that particular one-to-one session. And so you almost want to hold on to those. But the thing as a clinician I found, which I'm hoping will also happen here, is that just by moving some of those more stable clients out to shared care, it actually allowed me more time to focus on the people that might have been struggling a bit more. And whilst I found them more challenging at the time, once I had the space to be able to actually look and support and work with them in a better manner, in a more timely manner, it allowed me to do better work with them. So they ended up moving into the more stable section. So I'm hoping that my hope for shared care, it will also have a ripple-on effect throughout the ADS service, just with some of their clients.
I think it's good for the case managers too. I think that's quite rewarding to see your patient actually sort of going for and improving and getting to their goals and being able to go out into life. And even, as Pete said, there's certain people that actually like coming to the clinic and want to be engaging in that clinic. Even sort of working with them and saying, I'm not leaving you. Yeah. We're still going to be here. We're still supporting, but you can go and take those baby steps out into the community. I think that's important as well, that, we've talked about the support for the doctor, but also the support that the client's not being abandoned and thrown out is just as valuable. I think that's a valid point.